Right. Well, if we have a quorum, it is the top of the hour. I'm going to go ahead and get started because I have not one but two thrilling lectures to titillate and thrill everybody this evening. My name is Dr. Karen Mushler. I am an emergency medicine physician and medical toxicologist. As of this month, now I am working at Brooke Army Medical Center in San Antonio, Texas. And welcome to this evening's lecture series. I understand everyone can see my screen and everyone can hear me, so I'm just going to continue on. So, just as a warning, of course, as I am active duty, anything that I say is my thoughts and my thoughts alone. It is not representative of the United States Army or Brooke Army Medical Center or any other institution that you could possibly blame. It's only me. I have no financial disclosures to declare. So, when we are talking about pesticide, well, first of all, foremost, I hate agendas. We're going to learn about some pesticides. Then we're going to really limit the pesticides talk to just acute ingestions and exposures. Because if we start talking about chronic exposure to pesticides or environmental toxicology or food systems toxicology, we are talking about entirely separate fields of study that I am not really an expert in. Acute exposures, I got. The rest of it, really complex. And so we're just going to focus on the acute things for today. Then we're going to take a short break, and then we're going to talk about bitey critters, which is by far and away my personal favorite thing in toxicology and medicine. So I'm very excited to talk about it tonight. When it comes to pesticides, there's two important regulations that if you want more information, particularly for the US and a classification guideline, I do recommend these resources. One is the EPA and the United States government has the Federal Insecticide, Fungicide, and Rodenticide Act, FIFRA. That is the regulatory information in this country for pretty much any pesticide you're going to use. Link is there if you want to read more about the actual laws themselves. But if you want to read about the pesticides themselves, then I recommend the WHO guideline, second link down below. That is kind of the definitive resource for worldwide pesticides. And if you have any questions about who or what something is, that is the source to go to. When it comes to pesticides, we're talking about a really, really, really broad group of chemicals here. Some are things we see in other areas of toxicology because they're kind of multi-purpose things. A lot of them are incredibly specific. If that wasn't complicated enough, a lot of the specificity of these agents is on the individual level, i.e., like when I'm talking about a group of herbicides that we'll get to later, called like the insecticides, like the organophosphates. There's hundreds of organophosphate insecticides out there, and their individual chemistry and their individual production and packaging and all of that changes the toxicology of it. While there are some broad strokes that we can kind of lump these things together, it gets really complicated really fast with these agents. But kind of when we're talking about pesticides, we're talking about like killing noxious things altogether. Whether that noxious thing is a plant we don't want, i.e. an herbicide, or fungus, or insects, or algae, or rodents, whatever it is, all of those asides are designed to kill some sort of natural thing. There isn't one group of these that's particularly more or less dangerous than the others. As I already kind of alluded to, there's tons of pesticides out there, and you can't really cleanly compare one or the other to say, oh, this one's definitively more dangerous or not. So first things first is don't worry. If you have a pesticide exposure and you're calling me about it at the Poison Center, I'm also Googling it right away. There are a couple I know off the top of my head, but that number is far fewer than the number of possible pesticides out there. In that WHO guideline I listed or mentioned earlier, there's about 1,000 agents in that booklet. And so again, I know a couple off the top of my head, the rest I gotta Google too. And because this is one of those areas of active research and we're constantly trying to make newer, safer chemicals in this realm, there's always newer stuff out there. And so Google is my best friend as well in this instance. So, but to that point, a picture is worth 1,000 words and 1,000 of these Google hits. If you've got a patient who says they drank something, getting a picture of the something they drank will save all of us a lot of time. A lot of these words are weird words with no like classical language background. They're kind of invented terms and phrases, and they're not spelled in a normal way. So just getting a picture of what the substance is and what the agent is will save us a lot of time. In addition, most of these come in multiple strengths and varieties and formulations. So just because it's like Roundup doesn't mean 2 bottles of Roundup are the same type of Roundup. So we'll get to glyphosate later, but that's available in about 50 different strengths and commercial preparations. And of course, having a picture really increases the accuracy of our medical documentation, and it reduces the provider to provider variability in reporting, which I know we've all experienced to some degree or another. But pesticides aren't just the pesticide. When you talk about like a bottle of something, there's also liquid solvents, there are surfactants, acid base stabilizers, there can be heavy metals, creosols, phenols, hydrocarbons, propellants, and other stuff in that solution that can also cause human harm. And some of them can be pretty significant human harm, in addition to the actual pesticide chemical itself. So it is not always clear in these ingestions what is causing the harm. Is it the pesticide or is it the other stuff it's dissolved in? When we look at toxicity studies, we're talking about discrete chemicals, i.e., and for example, for Roundup, which is glyphosate, we're talking about pure glyphosate in those research studies. It's really not that toxic. When we're talking about Roundup as a chemical, though, there's a lot of other additive substances, and particularly the surfactants, that are suspected to be one of the primary drivers of toxicity for those ingestions. So it's not always just the one agent we worry about. So a lot of those things can be things like potassium hydroxide, which is lye, or those surfactants that I listed as well. Which leads us into, of course, part 2, which is that the chemistry and the route of exposure matters a lot. When we're looking at toxicity studies, it is oftentimes based on how the manufacturer intends the chemical to be used, i.e., if it is like a bug bomb for bed bugs. That is, they design those studies based on its proper use. One can at a certain time, at certain time intervals, with X amount of ventilation as appropriate. So when people use them against their labeling, our ability to accurately apply that toxicity information goes out the window pretty quickly. So things that change how worried I am is, one, the intentionality of exposure, i.e., is this somebody who walked into a recently fumigated structure too soon? Or is this someone trying to intentionally have self-harm, or have suicidal ideations or intent, and they're drinking a substance that you're really not supposed to drink? Age of the patient matters too, i.e., kids versus a healthy adult versus older folks. Small children have obviously a very different physiology than adults do, with a lot greater surface area, and they're a lot lower to the ground. So when we're talking about gaseous agents that are heavier than air, kids are more susceptible to that exposure because they're closer to it, and they have a higher minute ventilation for their body size. Similarly, older folks who are more medically frail, who maybe can't get away from a substance as quickly, are also likelier to have higher exposures than folks who are like young, healthy, middle-aged adults. Other things to consider is, again, like that route. Is it a dermal absorption or dermal exposure to skin? Is it inhalational? Was it an intentional ingestion? The chemistry for these different agents shifts a lot based, again, on how you're actually getting it into you. And as alluded to before, when it comes to the research on these chemicals and toxicity studies, they are predominantly designed through a intentional use, i.e., how that compound is supposed to be used, and not how we're getting creative with it. So a lot of the research is based on dermal exposure in animals and how much it takes to make that animal sick clinically. If you're drinking it, that chemistry is different. And then if the formulas are, of course, diluted or concentrated, there are dilute formulas available over the counter in a lot of places. But if we talk about specialized pesticide applicators, they have access to much more concentrated formulas. Similarly, if someone is out drinking this, I need to know, did they drink the diluted version they're spraying out in the field, or did they drink the concentrate? Furthermore, other things to consider is like, what is the person doing that got themselves exposed? I.e., again, like I alluded to, did they go into a building that they should not have walked into? Did they ignore the giant tent and like poison death signs? Is it someone who's got an occupational exposure where they might have gotten it on their clothes and didn't realize it or know, and had their clothes on all day and so have had really slow dermal exposure? Is it an accidental ingestion where somebody may have poured some pesticide into like a Gatorade bottle, which is in tox, at least like the most common cause for accidental exposures is people pouring things into Gatorade bottles and not labeling them and leaving them out and someone else thinking it's Gatorade. Or is it like, again, like a small kid? A lot of occupations have that risk of pesticide exposure, i.e., like people who are working on farms or in rural areas who are intentionally applying pesticides, but some other things to consider as well, or folks who are doing gardening who maybe don't know something has been used on an area or didn't know how dangerous the substances are that they've used or the environmental persistence of said substances, i.e., is it still sticking around a couple days later? Road maintenance workers, people who are doing like highway maintenance, they can all be exposed even though they don't really know they're going to do it or that they're going to be exposed. So, yeah, a lot of different people can be exposed to them. Other things to consider, like I've kind of already alluded to, is like how is the chemical supposed to be used? Is it a fumigant where it's going to release itself as a gaseous form pretty quickly? And then if you open the door or release the tent, like the substance is going to dissipate really fast? Or is it a liquid product that's really persistent in the environment? Though all of those things affect how much we worry about an individual substance and an individual exposure. And this matters because about 200,000 people on average have died every year since the 1950s because of intentional pesticide ingestions. This really peaked outside of the United States, particularly Southeast Asia and Sri Lanka in particular, really was the hotbed of these ingestions. And it peaked in the 90s and has declined since then, but we're still talking about 100,000 patients every year who die from these exposures. Most of these exposures, again, are intentional exposures, i.e., they are trying to cause self harm or suicide, and it's not the accidental or occupational exposures, but they are all important to consider because some of these agents are incredibly dangerous. So again, we're going to talk about some of these pesticides. Even I, as a giant toxicology nerd, I don't think I could tolerate 1,000-item long lecture. So we're going to hit some of the big groups, some of the like little famous and classically dangerous ones, but we're not going to talk about all of them. If there is something in particular you have a question about, we can try and discuss it. But again, there's a lot of pesticides out there and not enough time in the day to talk about all of their thrilling exposures. So one of the classics, first and foremost, we're going to start with is the metal phosphides. So these are used as fumigants in structures, particularly for grain. So we're talking about silos, boxcars, other kind of big areas of storage for products we want to use as food or exposures later, but need to protect for a while. So these are those kind of like grayish brownish tablets that comes in aluminum, magnesium, calcium, and zinc formulations, where it's those metal ions and a phosphate group essentially. And they work really well and they are super cheap. And as long as these tablets stay dry, they are harmless. But the second you get them wet with either water or a weak acid, it rapidly decomposes into a metal hydroxide and phosphine gas. Phosphine gas is the big problem because it is very flammable and incredibly toxic. It causes a cyanide sort of presentation where people get super sick, super fast. They're going to be tachycardic, tachypnic, hypoxic, and develop very bad metabolic acidosis and methemoglobinemia pretty quickly within about 30-ish minutes of an exposure. And people don't do great in the short version. That's if they exposed to the gas. Sometimes people will choose to ingest these intentionally, again, as a self-harm thing. It's just as fast and it's just as dangerous. And because you are then mixing that metal phosphide with the acidic environment of the stomach, that phosphine generating reaction happens even faster. So there's a secondhand risk to you as a pre-hospital provider with these agents. As I alluded to kind of in the intro, the gaseous form of this, if you release it into the environment, i.e. open the door, open the silo, it is rapidly dissipates and it is not persistently toxic. So it is safe to enter once it has been ventilated. And that is why it still is used despite its incredible toxicity, is because it is a very cheap, very effective pesticide for sort of those large bulk things. Once the reaction has happened and the phosphine and the pellets have decomposed, the metallic bits left behind are essentially non-toxic, and the gas kills all the living critters that might be in the grain and doesn't leave a residue on the grain. So all the stuff in that container is safe after it has been ventilated, and it works really well. Pure phosphine is, again, very flammable and odorless, but oftentimes, because of the way the reaction happens between the compound and water, you get some impurities that have kind of a bad, garlicky, fishy smell to them. And it's been reported that patients who ingest it also have that sort of garlicky, fishy, bad smell. So if you've got an undifferentiated patient who smells bad, but otherwise looks like cyanide, that is where I would perhaps suspect this. Like most of the other agents we're going to talk about today, there is no antidote for it. There's really no magic treatment. For a lot of these pesticides, there's basically not much we can do one way or the other than supportive care. So making sure you're protecting yourself from the patient and just doing good basic medicine, that's really all we can do for these folks. If they do have signs of methemoglobinemia, I would treat the same way I would treat any other methemoglobinemia patient with methylene blue, but I would have a low amount of hope for success, especially of an intentional ingestion of this stuff. Moving on to something totally different, we're talking about glyphosate. As I alluded to before, this is Roundup. So very common, very trendy herbicide that has greatly waned in its popularity and is a source of a lot of internet distress, I'll put it that way. But it's a source of a lot of internet distress in its chronic exposure form and not necessarily the acute ingestion. It blocks the plant's ability to do amino acid synthesis. And it blocks it through a system that we as humans don't have. So we don't really know why it causes human toxicity in the way it sometimes seems to do, because we don't have that same plant system. What we do know is that patients who intentionally ingest Roundup tend to develop kind of a dermal and corrosive burns, and they have signs of neurotoxicity in the sense that they have usually development of coma and seizures, and they have renal injury. But we don't know why this happens. We have yet to really come up with a good mechanism for it. And this is one of those agents that it's suggested that the surfactant in it, which is a polyethylene aminated hydrocarbon, is perhaps really the more toxic thing, because when we treat animals in sort of those laboratory studies with glyphosate alone, they tend to not really get sick from it. The toxicity, it is based on that WHO classification, one of the least toxic herbicides. When we mix it with the surfactants, it gets way more toxic and the animals get sick. When we treat the animals with the surfactant alone, they get pretty ill, but there seems to be a synergistic effect between the glyphosate and the surfactant themselves that leads to those really negative outcomes. So concentration is really key, as well as formulation. There's about 50 different commercial preparations available of glyphosate, ranging anywhere from like 1 to 50% concentration solutions. And so, as you can imagine, the lower end of those solutions are pretty non-toxic. As we get to those deeper and higher concentrations, the concern goes up a little bit more there. But it really is on an individual level before I can predict any sort of badness. Similarly, there's another group of compounds out there called the dichlorophenoxyacetic acid, 2,4-D. Is kind of the shorthand for it. There's a 2,4-D is one specific compound. There are a lot of other dichlorophenoxyacetic acid derivatives that are used as herbicides. They're also pretty nasty in that they act as an acid and can cause a pretty severe GI burn with lots of vomiting up front. But what makes them a little bit different, even though they kind of have a cyanide-like behavior, again, where they interrupt the cell membrane and the ability to do oxidative phosphorylation in the mitochondrial membranes, they usually present with a lot of vomiting, and then they fall into a coma. And then they got kind of cholinergic signs and symptoms, which we'll talk about more when we get into organophosphates later, but they can have a lot of muscular twitching and drooling and fasciculations that kind of look like organophosphates. And then they develop a metabolic acidosis. These tend to be a little bit slower than some of our other agents, and luckily they're not very common anymore. We have other agents that work better, so we don't see as many of these exposures as we used to. But one of the unique things, at least for the dichlorophenoxyacetic acids, is that there's evidence that charcoal will actually work for this group of stuff. So an early dose of activated charcoal may reduce the amount of exposure and toxicity for these patients. And because of their chemistry, in that they are essentially an acid that you have consumed and absorbed into the body and absorbed into the bloodstream, their binding chemistry is such that it stays in the bloodstream and can actually be dialyzed away. And though there aren't a ton of human studies on dialysis in this, there are enough, and the patients in those studies have done well enough that dialysis is recommended for this. So it's one of the few agents we're going to talk about that actually kind of has a treatment. We're going to talk about pyrethrins next. Now, pyrethrins are important because this is the largest family of commercially available insecticides out there. They are originally derived from chrysanthemum flowers. Chrysanthemum flowers contain these incredibly effective natural insecticides that are these pyrethrin family. It's a huge family of agents, both the naturally created pyrethrins in the plant, and then all of the semi-synthetic derivatives that we have made secondarily that work really well as insecticides. The actual plant itself works pretty well, but the problem with the naturally occurring pyrethrins is they rapidly decompose when applied as an insecticide in the presence of sunlight. They're very UV sensitive. So we designed all of these semi-synthetic pyrethroids to manipulate that chemistry so that they are very effective insecticides, but they don't decompose in sunlight as quickly as pyrethrins do. The naturally occurring ones are like completely gone within 24 hours of application. So as you can imagine, from a like large scale farming perspective, that is not an effective use of time and resources if you're needing to reapply the insecticide every few days. So these semi-synthetic derivatives last a lot longer, and in theory, they are fairly well targeted to specifically attack voltage-gated sodium channels within the insects themselves. And so when we see human exposures to it, we see kind of the same but different. Because in theory, it really shouldn't bother us, which is why it is so widely available as commercial preparations, is because in relatively low dose exposures, it doesn't bother us. The few cases that are out there of illness from pyrethrins tend to be smaller kids and or intentional exposures. So when we talk about this voltage-gated sodium channels, we're talking about kind of classic stuff we see with a lot of things, like any sort of inhalational exposure, which is the most common route. This is a lot of these things are like wasp killing spray and stuff like that are pyrethrins. You have respiratory sensitizations if you're inhaling a bunch of this chemical in the air. Unsurprisingly, it can cause, runny nose, cough, lung irritation sort of symptoms. The classical features are neuromuscular twitchiness and tremor. That is where we really started thinking pyrethroids. If you don't have a lot of other signs or symptoms, but you're acting really strange and you're real twitchy, that's sort of where we start thinking pyrethroid is the likely thing. And there's one case of a child ingesting a liquid preparation of a bug killing spray and having a very prolonged seizures. That being said, there have been very few fatalities associated with accidental exposure to pyrethrins, i.e. little kids walking into a space, adult humans walking into a space, there goes my cat, where the bug sprays have been recently used. Very rarely are there clinically significant features of those exposures. This is another thing, though, that we suspect the toxicity might be an additive and not the original compound. There's a chemical called puperonal butoxide that is added to a lot of these preparations because puperonal butoxide is not naturally an insecticide, but it increases the absorption of the pyrethrins through the insect's exoskeleton. And so while it does, in theory, nothing to humans, because we don't have a chitinous exoskeleton, the suspicion is that it might be more of the source of the toxicity than the original pyrethrins themselves. Again, there are hundreds of these available out there, so my ability to tell you which one it is exactly and how dangerous it is pretty limited, which also means that the toxicity studies are going to be pretty limited, and the likelihood of other patients having been exposed is really low. So we have to make a lot of extrapolations from one chemical to another. We do use pyrethrins medically. if you've ever used like permethrin to treat either like scabies or prophylactically treat hiking, camping, tenting gear, that those are pyrethrins. So you've used them before, most likely. Those of us in the armed forces, our uniforms are pre-treated with pyrethrins. It's permethrin again. So yeah, they're pretty common. Paraquat and diquat. Paraquat is the ultimate evil when we're talking about pesticides. These are non-selective herbicides that came onto the market in the 1960s, and it is potentially one of the most uniformly fatal substances available. The original, when this first came out, as you can imagine, rapidly available and accessible and a relatively cheap compound available worldwide as a very non-selective herbicide, rapidly led to a lot of people dying from intentional ingestions of paraquat. It works really well as an herbicide because it's fairly non-selective, i.e. there's not like any one plant that it doesn't work on because of how it works in the plants. And it is not environmentally persistent because it is rapidly deactivated when it binds to soils. So the chemical itself decomposes pretty quickly in the presence of like clay minerals. And so it is great to kill plants and not keep killing things. It is terrible in human toxicity. So in the 70s, the new formulations were made where they tried to dye it blue to make it less mysterious as to what compound you were drinking. Emetic agents were added, so vomiting agents, bitterants to make it less palatable were added. It didn't really stop anything. It decreased the exposures maybe somewhat, but it is still to this day really fatal. We're talking case fatality rates upwards of like 70 to 80%, depending on the amount ingested. Diquat was a secondary derivative of paraquat that was made to try and to maintain the herbicidal capability while decreasing the human toxicity. But unfortunately, diquat just kills you in a slightly different way than paraquat does. These are very corrosive compounds. When you get it on your skin or people drink it, it causes pretty rapid dermal sloughing. So like you'll just get like peeled up layers. People who have drank it will get peeling of the tongue. It's paraquat tongue because of that corrosive effect of the chemical compound on the mucosa of the tongue. It causes a lot of vomiting, whether that's GI corrosive injury leading to vomiting or the actual proemetic agents in the solution added that make people vomit. Doesn't really matter one way or the other. There tends to be really a lot of aggressive vomiting up front. And one of the things that we're taught as tox fellows is the common causes of blue vomit. One of them is paraquat. So if you have blue vomiting, be worried quickly. But what kills you in these cases is this incredibly fun reaction where essentially paraquat will hijack your NADPH NADPH system and becomes a free radical ion. And if that wasn't fun enough, it then reacts with superoxide dismutase and some other free radical management systems and just continues to develop oxygen-free radicals that then chew up every source of antioxidants that we have and cause severe cellular membrane death. The really big problem with paraquat is that due to some bioamine uptake systems that we have, particularly in the lungs will concentrate paraquat within lung parenchymal cells. The intra-lung concentration of paraquat can be over 50 times what the blood concentration is. And that reaction and that process happens fairly quickly in about 6 hours. And then there's just nothing we can do to stop this free radical reaction. So what will happen for patients is they'll get it, they'll drink it, it will continue to react and cause this free radical damage. And it basically just nukes their entire lung tissue. Patients will usually present with those symptoms we already mentioned, vomiting, they don't feel good, there can be otherwise like kind of sick up front. In the next few days, they develop worsening alveolitis, which then progresses to frank pulmonary fibrosis. and respiratory failure due to hypoxemic ventilatory respiratory failure is what kills these patients. And so nothing to date in research in medicine has done anything to stop that process from happening. If you transplant the lungs, it still happens because because this reaction is basically nothing can stop it. No medications have worked. Lung transplant hasn't worked to date. Very few people survive paraquat ingestions. About 50 milliliters is that magic number for a fatal ingestion. And if you think about in like freedom units, 50 milliliters is about a half a cup. So not a ton of solution, really fatal in a very slow and painful way. The only thing we can try to do is reduce that free radical development by not putting these patients on oxygen if we can avoid it. Relative hypoxia down to about 88% is tolerated for paraquat ingested patients, but they still don't do well. Diquat acts very similarly, but it causes acute renal failure and then just kind of kills your kidneys in a similar process. Again, people don't do great with these. Since we're on a roll with really toxic compounds, we're going to talk about the organophosphates and the carbamates. These are broad use insecticides, and it's the most common type of insecticide after those pyrethrin we talked about. And if you have listened to some of those, the mountain plains, like disaster preparedness lectures, and heard my lectures on nerve agents, these are those same things. So if you're familiar with things like sarin gas, organophosphates and carbamates are manipulating, get out of my way, kitten, that same system. And so what these agents do is they basically interrupt your ability to break down acetylcholine at the neuromuscular junction. And they cause that classic cholinergic toxidrome, where you've got the killer bees, a bronchospasm, bradycardia, bronchoria, and then everything else is also wet and slimy. You've got a lot of lacrimation, salivation, vomiting, diarrhea. Everything is oozing, and that is the cholinergic toxidrome in a short version. What is a little bit unique compared to some of the other ones is you get both nicotinic and muscarinic effects. So you get all of those mucosal effects as well as muscular weakness and twitchiness. Twitchiness first, weakness later. And as I've alluded to plenty of times already, your route of exposure matters significantly with the organophosphates and with how dangerous these things are and the speed at which I expect you to get sick. These compounds are all generally very lipophilic. And so what separates them from some of the other agents we've talked about is that the dermal exposure risk from organophosphates is pretty high, particularly because they act so slowly. People don't feel that they've gotten it on them. There's nothing that noxious about it up front, but you can absorb a lot of it over time, particularly if you've got like a backpack sprayer on and you're really sweaty. These compounds, their skin absorption increases dramatically with heat. And so being hot and sweaty and getting it on you can really increase that absorption. And so that route of exposure changes the time of onset of symptoms for them. So skin can be slow but severe. If you have an inhalational exposure with, again, we think of it sort of like the sarin gas classic one. In theory, you can get the same thing with these agents, but these tend to be not gas, these tend to be liquids. And so if you ingest it, symptom onset tends to be a little bit faster. But as I keep saying, there's a ton of these different agents out there with a ton of different ways they're prepared and packaged for subsequent use, i.e., chlorpyrifos, which is a case I had as a fellow in Tox Fellowship last year, is a like dried granular powder, and the patient tried to eat it, but that didn't work. And because it's so lipophilic, it didn't really get absorbed very well, and they ended up vomiting most of it out. So it was unclear how much they even ingested in the first place. And so our ability to predict a dose goes downhill pretty fast with some of these agents. This is one where we do have a treatment, though, and that for all of these agents, whether it's whether it's the nerve gases, if it's an organophosphate, if it's a carbamate, we can treat with atropine, and that is going to be our primary treatment. Atropine works at that muscarinic receptor, and it reduces or ameliorates the life-threatening bronchoria, bradycardia, and bronchospasm that kills these patients. The reason this works is because what is happening at the acetylcholinesterase enzyme is essentially this reaction where, regardless of which organophosphate you have, this one is methylperoxide in this example, that phosphate group can get stuck on the enzyme. And when that reaction happens, that sticks that phosphate group on to the enzyme, you cannot undo it. And that process is called aging. That aging process sort of predicts our concern for toxicity for these agents like the carbamates, which we use pharmaceutically. Pyridostigmine is a carbamate for folks that have myasthenia gravis. Like that reaction doesn't really happen with carbamates. It happens incredibly fast with some of our nerve agents like Soman. It's within a few minutes. That speed of that reaction varies based on which chemical we're talking about. Once it has happened, we cannot undo it. We cannot fix patients, and we have to wait for the body to resynthesize acetylcholinesterase to be able to recover. But when we're treating, this is what we're trying to reduce. If you notice on my list before, I only said atropine and a benzo, and I didn't talk about pralidoxime at all. The short version is I can't actually tell you if pralidoxime is going to be a hugely beneficial for these patients. Pralidoxime is trying to interrupt that reaction we just looked at by reducing the risk of aging at the acetylcholinesterase enzyme. The short version is for the organophosphate insecticides. We don't really know if it helps. And honestly, the data is pretty mixed about whether or not it's beneficial at all. And a lot of places just don't have it. They don't have enough. And even in large facilities like Denver Health, like University of Colorado, where I trained, like we didn't have enough to even treat one patient as a starter dose based on the literature that's available for these exposures. The important part is atropine. The short version is how much atropine? Most of the atropine you have, and then probably most of the atropine the hospital has. On average, with the with self-harm ingestions of organophosphate insecticides, most of the like starter doses for people to get them out of that killer bees where they're no longer drowning in their own secretions, their bradycardia is improving, and their bronchospasm is reduced. We're talking about 20 milligrams of atropine on average. So it's quite a bit. These agents, the way that acetylcholinesterase enzyme is present throughout the body, so we get a lot of different symptoms based on which of the like receptors we're talking about, because the acetylcholine system is so broad. You've got receptors everywhere, and it causes stuff everywhere. What is fatal for these patients is a combination of central nervous system effects and respiratory effects, and the tie-in between the fact that they can be centrally apneic from the effect on the brain from these agents, and you can also have muscular paralysis from the nicotinic effect at the acetylcholine receptor in that neuromuscular junction. The multiple ways that you can die from these agents, and that's why midazolam is also beneficial and maybe not prophylactic for anything specifically, i.e. seizures, but I'd have a very low threshold to give it because there is some benefit potentially to treating early with it to reduce the risk of seizure. Honestly, I can't say like definitely do it, but I would have a low threshold to do it. Now we're going to move into a totally different group. That is another fun manipulation of natural biochemistry. We're going to talk about the superwarfarins. What is a superwarfarin? It's like warfarin, only worse. These are brodifacoum, bromadiolone, and difenacoum, which are classically used as rodenticides. They act exactly like warfarin. They inhibit your ability to do vitamin K-mediated cofactor metabolism in the liver, and you don't make all of the clotting factors you need to make. And unlike warfarin, the half-life is in months. And so the problem with these agents is that they work pretty well as rodenticides because they cause mice to bleed out internally. But then for humans, they also cause the same thing where you are going to be basically anticoagulated for many, many, many months. They are not super acutely toxic, i.e. if you ate a bunch of rat poison, you're not going to drop dead right away because that's not like how bleeding works. You will be fine as long as you're not bleeding. But if you're bleeding or not knowing you've been exposed, it can be a problem. And brodifacoum in particular has been found in homicide attempts and as contaminants for other things. So there was a couple of years ago, Verdificum was found in some synthetic marijuana, so it made a ton of folks super anticoagulated, and they didn't know they were. And then recently, actually, like because the future is today in Australia, where this one came from, there were a bunch of people that had rat poison in their takeaway food. Is these kind of like blue bricks that you see here? So it's again another source of like potentially blue like mucosa or fingertips if you see it. And you don't have to panic as long as the blood is in their body. And so as long as they're not bleeding out, there's really not a ton of other acute toxicity to be worried about with them. But we are talking months of vitamin K therapy for these people, if not like upwards of a year. I want to round this out with another classic, strychnine. This is naturally derived from the Strychnos nux vomita tree found in Southeast Asia and Australia. And it's an incredibly fast acting neurotoxin that we used to use a lot for rodenticides. But it turns out if people get it, we have a very bad time as well, because the strychnine molecule is a rapidly absorbed alkaloid that gets bound to the brainstem and spinal cord glycine receptors and basically blocks our ability to have any sort of effective neurologic off. So it blocks glycine, it blocks GABA, and so all you get is neuromuscular excitability. And as you can imagine, that leads to a pretty bad time. Such as this person here. This person actually probably has tetanus, and unfortunately, this person did pass away. Tetanus works same but different to strychnine. They act at the same spot, but the tetanus prevents the release of GABA and glycine. Strychnine stops the binding. And so you get this something called epistotonus, which is this incredibly intense contraction of particularly the posterior muscle group, so the spine here. And there's a couple of other things. A sardonic smile, rhisis sardonicus, is another classic finding where you kind of grimace because you can't relax the cheek and jaw muscles. And people are described as having awake seizures where they've got really violent convulsions and they're in that sort of contracted posture. But unlike a true seizure where there's altered mental status afterwards, some degree of post-ictal state, these patients are awake and aware and miserable because strychnine does not cross the blood-brain barrier. So they are fully aware in their sensorium and just having these incredibly bad spasms. You are not wrong to give them all the benzos, all of the barbiturates, and potentially paralyze these folks because they end up dying from respiratory muscle fatigue and paralysis or complications of rhabdo and metabolic acidosis from this much muscular activation. And yeah, luckily we don't see this as much as we used to. It was taken out of common circulation in like the late 1940s, but it still does exist. It's still around. So if you ever see patients that look this bad, think tetanus or strychnine. So to kind of summarize what we talked about, one is don't touch it. I know all like pre-hospital training and all of the stuff that we do as physicians for like ALS and BLS is like, is the scene safe? And for these exposures, it's going to be don't touch it. Like make sure you are not going to be exposed to the chemical as well. So if it's something somebody has ingested and they're vomiting, like don't let their vomitus get on you if you can prevent it. If they're covered in a liquid solution, like take their clothes off at least and like roughly decontaminate them. There's not a lot of magic to a decon for these agents. It's soap and water, like pretty much anything else. But like, don't let them get on you. As I alluded to before, and I kind of talked about with this kind of broad overview, is there's not a magic trick for any of these. There's no antidotes really. There's not a lot we can do. My asterisk and special techniques is because it's going to be don't give oxygen for paraquat and give atropine for the organophosphates. But like beyond that, there's not anything magical. If they're seizing, give them benzos. If they're hypoxic, except for paraquat, give them oxygen. Like it's all supportive care and it's all we can really do. But to that point, be willing and able to aggressively manage seizures in their airway because of how a lot of these compounds, as we've talked about, so we have a lot of neurologic and respiratory symptoms. So, or secondary respiratory problems from a neurologic problem. So be ready to do it. So, and this is a quick, again, summary, like, don't worry, I'm Googling it too. I don't have them memorized. I got to double check which one it is and what category they fall into. Don't touch it. No oxygen for paraquat. Give atropine for an organophosphate exposure until their breathing improves. and then like don't breathe the phosphine or strike a match around it. So on that note, take a quick break here. If anyone's got any talk about them or answer them, I see there's some in the chat that have appeared while I had the other screen up. And so to one question for cyanide, what about Sanokit? So the short answer is probably not. Hydroxycobalamin works to basically pull the cyanide moiety off of your cytochrome A3 site. These agents interrupt different parts of the metabolic transport chain. And so it's cyanide and the fact that you end up with an inability to use oxygen appropriately and a pretty severe metabolic acidosis, but they're acting at different sites. And so I can't say if it would be effective. Is it something you could maybe like Hail Mary attempt? Maybe, but it would be kind of a wild thing to do because hydroxycobalamin is pretty specific for cyanide. Yeah, it's a solution flammable combustible liquid, xylene and toluene. So yeah, to the person that talked about xylene and toluene, toluene and xylene both have their own unique additional toxicities, which is beyond the scope of this lecture today, but they are both pretty cardiotoxic. So to your point is that like when we're talking about a lot of these pesticides, the stuff they're mixed in is arguably just as important as the actual pesticide themselves. For things like glyphosate, like the dermal toxicity of glyphosate is measured in grams per kilogram of body weight. Like you can rub that stuff on you all day long and nothing happens. But if you mix it with that surfactant that it comes in a lot of times, like it gets rapidly absorbed. It's rapidly bioavailable and it causes a lot more toxicity. But if you rub that surfactant on yourself as well, you get that same clinical effect. So for a lot of these agents, it's a toss up to which is the more dangerous part. Is it the stuff it's mixed in or is it the actual pesticide? So hopefully that answers most of those questions.
Doc, I just have one more question is, do our nitrile gloves and most of our commonly used PPE, you said obviously except breathing in, or getting puked on, does most of our standard PPE that we use help prevent kind of any danger to us?
Yeah. So
Okay.
from what we know anyway, most of these things, honestly, a lot of them haven't specifically been tested. But from a PPE standpoint, I don't have a better recommendation for, at least for this pesticides. Now, like would I recommend like keeping the nitrile gloves on all for a nice long ride to a hospital that you've got some, especially for some of those more lipophilic like the organophosphates? Like, no, I would recommend definitely changing them out. But otherwise, like I don't have anything else I can recommend, and it hasn't specifically been studied. There's certain other compounds out there, dimethylmercury, which is not in this talk, that can penetrate gloves, but the stuff that can rapidly penetrate nitrile gloves is usually an exception and not the rule.
And then what do you think? Just like a couple minute break, or does everybody want to keep going? Doc, do you want a few minutes and then come back, or do you want
keep going? All right. Well, I'm going to take a sip of water and then I'll keep going.
Yes, please. And you guys, just so you know, continue to drop the questions in the chat. It's kind of easier to come back and do them all at the end. And then when we're in that question time, if you have one, feel free to just come off mute too. You don't have to type it in.
Yeah.
I just have one more question, I think, on some of these. Do we need to, I guess, is there a need to be worried about them being used in an attack manner, not being used in on the farm or for a suicidal attempt,
Yeah.
things
So
like that?
the short answer is it depends, of course. There is some concern for something like phosphine or the metal phosphides, which can be readily hydrolyzed into phosphine that could be potentially used. Would it be great in like an outdoor environment? No, because it rapidly disperses. Would it be good in a closed space, like if you were trying to murder a household of people? Like, maybe. Um, Thankfully, has it been used to date? No, but it does. It can happen. There are a couple of like mass outbreak cases, especially for like liquid insecticides decanted into Gatorade bottles. Which, like, man, I can't tell you how dangerous the Gatorade bottle is as a toxicologist. Uh, the number of cases, like, even the cases I've had as a fellow, probably like the dozen of like people who put something in a Gatorade bottle and someone else drank it. Like, so those exposures, yes, which, so technically to your point, yes, that can be a mass count mediated sort of event based on that. Has it been used? No. Is it always possible? Yes. And since for a lot of these agents, we don't have like a quick way to test. Even something
Mm.
like paraquat, which is classically like has a pretty well defined syndrome. People get super sick on kind of a predictable manner. Like, it's so infrequent in this country that like it would be hard for a pre-hospital provider, for an ER provider, and like honestly, probably people would probably get me involved until a day or two later when kind of things are set in motion for a lot of these agents that it would be hard to identify. The ability to identify one of these compounds after exposure is very expensive and very uncommon. So we're talking about like reference labs days later before we could get an identification reasonably for
Okay.
most places. In my one chlorpyrifos ingestion, which was in, I can't remember where it was in Colorado. It was like southwestern Colorado. Like, the whole problem was that they didn't have praloxine like at all. And so we basically just managed with atropine and the DAS, and then he was more fine than we expected. So like we're generally not prepared is the short answer to manage these
Yeah.
cases. Um, and so thankfully in the United States, they are still pretty uncommon. When we compare epidemiology of these exposures worldwide, it is far more popular in Southeast Asia and India than it is in the United States for whatever reason. Our cases in the United States are much more misuse of commonly available preparations leading to problems for people. I like people using bug bombs and not ventilating afterwards, or people entering fumigated houses, even though there are many signs that say, like, if you enter, you will die. Uh, that is where we more commonly see issues in the United States than we do for intentional ingestions, thankfully.
Oh, yeah, it's kind of hard to fix stupid.
I just, yeah, I got nothing. So some of them are really sad because like there was one for one of the few like pyrethrin deaths was a relatively like immobile, feeble woman whose husband was trying to treat bed bugs, so he put off like 5 of the bed bug bombs in the room, and then she like walked into the room and couldn't get out, and then died for various complications of her own baseline poor health and this exposure because she couldn't get away from it. Yeah. But you're not
I
supposed to use
mean,
five at
if
once.
we're
You're supposed to use
talking
like
bed
one.
bugs,
So
like I might just choose death if we're talking bed bugs.
yes, but maybe not, your partner's death. So,
All
all
right.
right.
Sorry, I'll let you go.
No problem. Now we're talking about my most favorite subject. We're going to talk about the bitey boys and girls. I love venomous creatures. They are my favoriteest thing in the entire world. I love lecturing on the subject, and so I'm going to try and keep myself within our time limit. However, I make no promises. Same disclosures before. This is all my stuff and not the U.S. government. Please don't go after them for what I've said. If you are not a fan of these critters, perhaps just listen to this lecture. There are lots of pictures, lots of snakes in particular. And so, yeah, this is your trigger warning if you don't like these guys. So, snakes will bite you if you tempt them to. There are, well, it varies from year to year, on average, about 8,000 snake bites in the United States, with about 5 deaths per year. It varies pretty significantly year to year how many folks die. It's been a pretty light year in the last couple of years where we haven't had a ton of deaths, thankfully. But it can vary. These snakes are pretty well distributed across the country. You've got venomous snakes up into Canada, but they do tend to condensed where it is warm. So southeast and southwest has a much greater concentration of snakes, and they're very summery creatures. So warm weather, unsurprisingly, as reptiles, they tend to come out when it's hot. The American versions of venomous snakes are honestly like kind of wimpy, and I say that with a lot of love for venomous critters, but like ours just aren't that bad. There's not great, but like they're not that bad compared to the ones worldwide. Um, Worldwide, we're talking about on average about 2 million snake bites per year, which leads to almost a million people with a clinical envenomation syndrome, of which about 50,000 of those people will die, and about 200,000 of those people are going to be left with permanent disabilities of some sort. Uh, as you can imagine, like rural subtropics and farmhands with poor access to medical care are where we see the greatest concentration of those negative outcomes and deaths, but it still happens in the US. Not all bites end in envenomation. Envenomation being the phrase for like the venom got put in you and now you are clinically ill from that venom effect. Not all the bites do. About 25% of them are what we call dry bites, where there's no venom, that you just literally got bit. And most snake bites are because you were messing with them, unsurprisingly. Uh, when it comes to across the country, every state except Hawaii has venomous snakes. The greatest concentration of venomous bites are in Florida and Texas. Arizona has the most highest number per capita. They have a ton of excitingly dangerous snakes out there, and kids make up about 20% of snake bites. So, importantly, and please, as a toxicologist, don't put a tourniquet on in the United States. Don't rub dirt on it. Don't use a venom extractor. Don't electrocute the bite. Don't try and cut out the venom. Don't get drunk after a snake bite. Don't pee on it. Don't suck out the venom, and don't panic. Like, none of these things help. Specifically for the United States, do not apply a tourniquet. And these venom extractors that you can buy on the internet are absolute garbage that literally do nothing. So the first rule, like to best way to avoid getting bitten by a snake is to just avoid the snakes. Sounds easy, yes. I'm a very strong advocate for snake protection. Snakes are generally like anti-people, so people who are getting bit either didn't know they were in a snaky environment, i.e., they like stepped on the snake. In my cases in fellowship, I had fell on snake, put hand on snake while rock climbing, peed on snake, believe it or not, and then like kicked snake is like the cases I had. So like all these things, like the snake was just trying to live its life, and the human interaction is what led to them getting bit. They're not going to come get you. They are not aggressive. They're not like, they don't want to be involved in your life. Our natural human environment is not a very snake happy environment. So if you are getting a lot of snakes, it's probably because you have a lot of snake prey, i.e., mice and rodents. So if you've got a lot of snakes, you might want to get your mouse problem checked out because that's why they're there. So too aggressive. When it comes to snake protection, like I said before, like decrease the vermin in your life. Look before you step. So carry a walking stick if you're out hiking, like pay attention to where you're going while hiking. And then protective gear is pretty much boots, pants, and possibly leather gloves if you're doing something like gardening in a really snake heavy area. You can't be envenomated if they don't penetrate your skin with their fangs. So when it comes to snake fang size, it is directly related to the size of the snake. So big old like Western Diamondbacks that are like pretty chunky boys are going to have much larger fangs than some of the ones in Colorado, like the Massasauga, which are much like smaller snakes overall. So if they can't penetrate your leather boot, they're not going to get into your foot, and thus you will have no problems. And the snake's going to have a bad day, but like you're going to be fine. So that is an important thing for like protection and prophylaxis, is just making sure you are using basic PPE for outdoor activities. If you have a snake bite, like, and do just like call us, we're here to help. This is what I love. So like I'd much rather be called. In the state of Colorado, you have a ridiculous number of toxicologists, and a large number of us are really big fans of snakes. When it comes to IDing the snake, the answer is don't. It's not helpful in the United States. Our rules for venomous snake ID are imperfect at best. Like they're broadly, vaguely helpful, but that's kind of where it ends. They tend to have heavy bodies, like they're bigger, thicker snakes. They kind of have a triangular head. Rattlesnakes will have a rattle at their end of their tail. But if we're talking about folks who are like in Kansas and more towards the eastern side of the country, you have plenty of vipers, but not that many rattlesnakes. And so rattle or not doesn't change the venomousness. They have two face holes. They've got a true nose, and then they have something called the L'Oreal pit. The L'Oreal pit is the heat sensing organ, that infrared sensing organ that they use to hunt their prey. And in this country, it does not matter what the snake is. We'll get into the treatment options, but you basically have two options that are probably clinically pretty similar. So picture's worth 1,000 words. You kind of have a vertical slit pupil, as you can kind of see in this picture. If it's a rattlesnake, you'll have these little horns at the end of the tail that make that classical rattling sound. You can roughly guess the age of the snake based on the number of horny buttons here at the end. With the longer they are, the older the snake, but they can break off, so it's not a perfect thing. And you can see in this picture here, he's got the two little nose holes out of the heat pits and then the actual true nose. If you're in a place with constricting snakes, which we don't have a lot of constrictors in the United States, they have a wider array of those sensory organs than the vipers do. Snake safety, again, like they like hot places. They're ambush predators. If you can't hear the snake, that's kind of on you, my friend. If you have earbuds in, like take them out. I know we talked about it earlier, like boots, gloves. So ankles and hands are by far the highest risk for envenomation, which kind of makes sense. So for the state of Colorado, the answer is you've got rattlesnakes everywhere. There are 3 venomous snakes in Colorado. There is the prairie rattlesnake, Crotalus viridis. There's the midget-faded rattlesnake, which is Crotalus concolor. And then there's the western Massasauga, the Cistrus trigeminis. The Massasauga extends out further east into Kansas and then south. And so that guy is relatively small and pretty widely spread. The prairie rattlesnake is pretty limited to Colorado and then north into the Cascades from there. Most of the bites in Colorado are going to be from the prairie rattlesnake. A lot of research has been done with their venom because they are relatively common. As you saw in the previous slide, they cover most of the state below about 9,000 feet in altitude. And so they are pretty much everywhere. They're not particularly like aggressive. They're the most aggressive of the snakes in Colorado, but that is still pretty significantly less aggressive than something like the western diamondback out in Arizona, which is generally a meaner snake. Most of our bites statistically are going to be the prairie rattlesnake, and they are fairly interesting from the venom studies that have been done from University of Northern Colorado with Dr. Mackessy's group. They've done a ton of research in here, and this snake has been the model organism for a lot of the variability we know about snake venom. Because it turns out that we're seeing it more in other species, but it was first defined with this prairie rattlesnake that you can have dramatic differences in subtleties of that venom production. So it's not so dramatic as to like totally change your medical management, but you get a pretty different compounds based on if you're north or south of I-70 and if you're east or west of the Cascades, which from a nerd perspective is incredibly interesting. It doesn't change a whole lot from a treatment place, but like for me who likes to think about enzyme concentrations, it's interesting. The next guy we're going to talk about is that midget-faded rattlesnake. It's a small snake, as the name might suggest. These are generally not aggressive. They're honestly kind of hard to find. And so these bites are pretty infrequent overall. They don't really want to be messed with. They don't really want to mess with you. And so they're relatively infrequent. And the Massasauga, much more widely spread and kind of in that middle ground from like its relative aggressiveness. And so they're a venomous snake. They don't cause a ton of bites, luckily, but it's possible. And then added to this lecture are the Echistrodons. The Echistrodons are vipers, so they are venomous snakes, but they are not rattlesnakes. Because I talked to Dr. Farkas and she said we got some folks joining potentially from eastern Kansas, and that snake prevalence changes pretty dramatically as we exit Colorado and head further east. Colorado has very, very few, if any, Echistrodons. The further east you go, the numbers shift dramatically to having almost no rattlesnakes and a ton of these guys. So this is going to be that classic copperhead and cottonmouth. Copperhead is obviously the dude on the left there. They're very orangey copper color snakes with a lighter colored head than the rest of their body. And and a relatively common cause of envenomations in the Southeast United States. And then the cottonmouth, which is that fun GIF on the right there, demonstrating its namesake of the fact that they have a very, very white mouth, are again super common source of envenomation, particularly as you go further east into southern Texas, Louisiana, Georgia, and the rest of like the Southeast United States. They're one of the most common causes of envenomations. Their venom tends to be a little bit more tissue damaging than our snakes. Our snakes in Colorado tend to be a little bit more blood toxic. They tend to be a little more tissue toxic. But they are, as you can see, a little bit meaner, maybe on average. Cottonmouths are also found in water, which people are not always looking for those snakes. And as some like fun snake trivia, cottonmouths have about 200 different regional name variations based on exactly where you are in the southeastern United States. Most of the names suggest something involving like a white mouth, but they've got a lot of different like hyper regional names, which is kind of interesting. This is a little picture of a copperhead I took during a venom conference, and one of the reasons I want to include it is because it's a really good demonstration of like why saying things like, "Oh, look for a vertical slit pupil" aren't helpful, because this is definitely a copperhead. But as you can see here, it's got two nose holes, but that pupil does not look like a vertical slit. Like it, I wouldn't think that was fits the like classic like venomous snake definition just by looking at it if I'm busy trying to not get bit by it. So all of those rules that you've been taught about, like how do I ID a snake, like those are nice, but they're not important in an emergency. Because what do you do if you've been ID'd bit by a snake? You don't ID it. Again, as I talked about earlier, it doesn't actually change how we clinically manage these snakes in this country as long as it's an American snake. So what I mean by that is like if you're at a zoo, particularly Denver Zoo has some fun exotic snake species. There are people who are snake collectors who have fun exotic snakes. As long as we know it's an American snake, that is sort of where our need to identify it ends, because we only have two treatments and it doesn't really change a whole lot from there. So I've alluded to it, but I haven't explained it. Like, what is venom? Venom and a venom gland, especially in these snakes, is essentially a specialized salivary gland that exists.
I'm hoping the good karma comes my way,
I mean, we got somebody hot miking. So the specialized salivary gland exists in the upper maxilla of these snakes, and they basically have a muscular band that kind of wraps around the salivary gland, which provides them some degree of volitional control of this highly specialized mixture of proteins, enzymes, lipids, and other small molecules that can have a variety of clinical effect. What makes it super interesting for me is that venom demonstrates a lot of convergent evolution. So the snake venom varies based on the age of the snake. It based on what the snake's primary prey is. It changes with snake age to change with its prey as it becomes juvenile versus adult forms. It can be variable based on geography. And it can also be variable based on sex of the snake. So it's really interesting if you're me. Clinically, what do we do with that information? Like, not a whole lot as of yet. Most of the snakes in this country are going to, most snakes worldwide are going to be kind of one of three flavors. You're going to get neurotoxicity, you get hemotoxicity, so coagulopathies, or cytotoxicity. And how much of any one thing you get kind of varies on those previous factors. Like, are you a viper? Are you a rattlesnake? Are you a southwestern fun rattlesnake that tends to be a little bit more neurotoxic? Or are you like an international snake, like a mamba, which causes almost purely cholinergic toxicity, or a taipan, which causes very potent, rapid collapse neurotoxicity? In this country, ours tend to be a little more coagulopathic on the West Coast and a little more cytotoxic on the East Coast, but generally some degree of both, kind of like across the way. What that means for your patients is that a lot of them are going to have some degree of pain, tissue destruction, and swelling. In addition to that, you're going to have bleeding and you're going to have pretty bad coagulopathy. And then that all mixes together. You get like hemorrhagic bullae, you get a lot of ecchymosis, you get a lot of tissue swelling, and it's kind of like intradermal bleeding, which is kind of funky and unfortunate. But like that is what that venom is doing. And it's doing that through a variety of those different enzymes. Predominant families being things like phospholipases, disintegrins, which interrupt our ability for platelets to behave appropriately. The phospholipases kind of break apart cell membranes, so you get swelling and a lot of bullae formation. And And then and there's about 15 other enzymes involved or can be involved that can cause all kinds of the same sort of destructive processes. So pre-hospital, what do we do? Again, don't try and identify the snake. Don't try and capture it. Please don't bring it to me. Like, I love snakes, but like, I don't want it in the ER. No one wants it in the ER. Our snakes are generally not emergently fatal. Asterisk, but generally not. And as I talked about before, just because you're bit doesn't mean you're envenomated. So when you've been bitten by a snake, the first thing to do is like, don't panic. We have time to think about it. We can be smart about it, and we don't have to, start freaking out. As I talked about before, do not tourniquet in the United States. Do not tourniquet. Do not pressure immobilization bandage. If you've Googled snake bite management and you've talked and seen things about pressure immobilization bandage, those are helpful in pretty much Australia, where they have certain neurotoxic snakes that are so deadly so quickly that it is the only intervention to try and get people to a hospital, essentially. In the United States, our snakes are not that neurotoxic, and concentrating that venom in the limb tends to lead to much more severe negative limb outcomes, i.e., it increases the rate of compartment syndrome and secondary complications for skin and soft tissue, and increases that risk of local tissue damage. It also importantly, does not improve outcomes in the United States. So I strongly recommend not using a tourniquet. If someone before you got there put a tourniquet on, do not take it off until you can get antivenom into the patient. But generally speaking, like, do not tourniquet. It does not help. You can splint for comfort, i.e., if they've been bitten on the arm, put them in a sling. If they've been bitten on the leg, like, try and keep their legs straight and keep the limb below the level of the heart and transport them to a facility that has antivenom. I'm assuming most people don't have pre-hospital antivenom. I do know that most of the hospitals throughout Colorado, even in critical access areas, do have antivenom because of the prevalence of these snakes. But yeah, it is not a place to like wait and play, and it's also not a time to like panic about things. Helpful stuff is to mark the outer borders of the area of tissue change after an envenomation and time it, and then progressively monitor that site. So particularly rapid spread is concerning to me. If it's starting to swell pretty dramatically, that we need to know. It helps determine how much antivenom to give and how quickly. And it can just help us out later on, essentially, for our risk assessment. Immediately after a bite, it may not look like a whole lot. So these enzymes take time to cause problems. And the bite site may not look like the two classic puncture wounds. Like we think about, two fangs, it hits you, you're going to have two pokals. As you can see from this picture here with this glove on, this only got one fang sitting in here. So you can have just one fang and get venom put in you. You can have a grazing strike and get venom into that wound. You can have multiple strikes. There was a patient at my facility very recently who got hit 3 times after he decapitated the snake. So it was an important point. Like, if someone has killed a snake, the neuromuscular system of the snake does not die off immediately, and it can still reflexively close its jaw, and it can then hit you and put venom in you after death. So yeah, don't mess with them. And so yeah, they can look like anything. And then what they look like over some time is like I kind of talked about. You've got bullae formations, so those big kind of nasty blisters. They're oftentimes hemorrhagic, so they kind of bleed into those spaces. As you can kind of see with this finger, you've got that kind of like dense ecchymosis and get bleeding in between the tissue layers. Your platelets don't act right, your blood vessels don't act right, your skin doesn't act right. So you just kind of get like a lot of oozy bleeding. And you can see it on this leg too, where they clearly had a tourniquet on. The bite was down on the foot there. You got this kind of really dense ecchymosis throughout. That's really common with snake bites, especially if it's in a dependent area, i.e. the leg. Like you'll get this sort of like, the whole thing will look bruised, essentially. This was a case I had in Colorado. It was a 14-year-old kid who got bit about 4 hours before these pictures were taken. As you can see there on the finger, he's got some of that kind of like ecchymosis in and around the fingertip here. His hand got pretty swollen. And then it didn't really progress a ton because he got antivenom within like 3 hours of the bite itself. So what we do in the hospital is we give the antivenom. The things we use to determine that is how quickly is that site swelling. So that's where that pre-hospital demarcation can come into play, is that you can get really, some people will swell really fast, and especially if it crosses a joint, i.e. you got bit on the foot and now it's up above your knee with a swelling, like that is very worrisome to me as a provider. We do it based on those lab abnormalities. Coags, CBC, and fibrinogen are kind of the three mainstays for what we use to determine progression of illness from an envenomation and how to redose. And so that is what we're checking every so often. Patients who are having really severe nausea or uncontrollable pain are worrisome to me. Particularly nausea tends to be a bad sign, especially in kids, if they've got really like recalcitrant nausea and vomiting. And then significant vital sign abnormalities. Now, I know what you're thinking. You're like, Doc, you just talked about how most of these patients are kind of fine. And they are, for the most part. But every so often, they're not. There are cases of what we call rapid collapse after a snake envenomation. And what we don't know is why those people have that. Rapid collapse being very much what you would think, where they've got really severe hypotension, they can be really tachycardic, pretty altered pretty quickly. And there's some theories like, did you get the snake venom directly into a vein or an artery? Are you allergic to it? Are you having an anaphylactic reaction? And the short answer is we just don't quite know. It's infrequent that it happens, but when it does, that's obviously like a 4-alarm fire. It's a bad time. Those are patients that need to be lights and sirens and scoop and run as quickly as you can get them to a healthcare facility. And then it's a bad time for us too, because they need to get treated. They need to get treated very quickly. And so generally you can match your panic to your patient. So if things are very bad, go lights and sirens. If things are not so bad, you don't need to rush necessarily. So what we do for treatment, and again, I keep talking about, in the United States, we have 2 options. I am not receiving any financial benefit from either company. I just happen to like their marketing for both of them. So, and they're helpful, I think, visual tools. So I have both of them on here. The classic one is CroFab. This is our older agent. It came out in the early 2000s, and it's been more used for longer. It is a single Fab fragment antibody that is made in sheep, and we use it. Historically, we used it up until about the 2018 when the other one came out. So it was the only one for a while. We start with 4 to 6 vials for this stuff. If you're panicking, the answer is you then start with 10 to 12 vials, and you give them basically that big load of fluid, and then you wait and see what happens. If patients are really sick, we check labs about every 2 hours and then kind of extend that out based on feelings and how much we're worried about them. If they're really sick, we check every 2 hours. If they're not so sick, like every 4 to 6. We redose based on the FDA packaging. They say redose every 4 to 6 hours for ongoing symptoms. We don't tend to redose as much these days. If they're staying fine, if they're not staying fine, we do. But we're not really talking about like a lot of CroFab until we fit like 24 plus vials. The other agent is Anavip. And this is 10 vials up front, and then another 4 vials later if they're still coagulopathic or symptomatic. And a lot of Anavip is 30 plus vials. So as I've alluded to, we got those 2 options. Outcomes are similar between the 2, and there's no major preference or reason to give one versus the other. It tends to be whatever that facility is stocking. They are in research studies efficacious equally for all American snake bites, even though they are made with different snakes. Anavip is made with South American snakes. The CroFab is made with purely American snakes. They are equally as efficacious in managing these snake bites. And so there's no reason to go to one hospital versus another. There's no reason to worry about which agent to use if you happen to have one, or if you're in a facility that has one. They are equally as beneficial. We do have more clinical experience with CroFab because it's been around for longer. So as of this year, there's been a few publications that might suggest regional variability and efficacy of these 2 different ones, whereas Southeast United States might be a little bit better treated with CroFab versus the Southwest. But again, functionally does not matter as of this time. It's whatever the hospital, whatever the pharmacy is stocking. So if antivenom is needed, you're generally going to be hospitalized for about 24 to 48 hours. And a lot of that depends on how good the treating provider, particularly in the ER, is about giving aggressive amounts of antivenom if needed. It's about how their labs do, and then really getting OT and PT involved and the extent of their tissue injury. That is what tends to be the bigger determining factor for complications. While there is a theoretical risk of anaphylaxis to both the snake bite itself and to the antivenom, that risk from the antivenom is less than 2%. And in the recent study that was published on it, there was none of those cases were true anaphylaxis. They were like itchiness and like feeling flushed, more so than any other like truly emergent condition. And so as of this, as I say, yeah, we should be prepared for it, but it doesn't change what we do for folks. And the extent of the tissue injury tends to be the big problem. That is where we see a lack of attention to detail for physicians, particularly emergency medicine physicians, if they aren't as aggressive treating because it doesn't look bad. That is where we can see some really negative outcomes for people as it evolves over time. In the case of this facility that I'm at now recently, I had horrible outcomes. And when they were telling me what they gave for antivenom, I was very disappointed in the lack of enthusiastic use of antivenom, I'll put it that way. So things we don't know. Kind of already alluded to it. We don't know why some people just seem to die from this. We don't have a good reason. There's not any clinical signs. A lot of these patients don't have a lot of snake exposure history because you can become allergic to snakes if you're a snake handler or a herpetologist, but like a lot of these cases aren't. So we don't know why they just suddenly dropped dead. We really don't know long-term stuff for snakebite patients. A lot of the snakebite research is like, did you die? And then we didn't follow them up afterwards. So the long-term outcomes, physical therapy, occupational therapy, that sort of information is active area of research, with certain states doing some more of that research than others. But the short answer is we don't know. It seems to be if you do well in the hospital and you're discharged about 24 hours, most patients tend to have some degree of swelling for upwards of 3 months after a bite, with most of that resolving in that first month and some lingering stuff as it goes on. But this is all based on very small patient data pools so far. And so we're kind of continuing to evolve with those things. The other stuff we don't know, we'll talk some about some of it later, some other like active areas of research, but we're going to switch to some spiders right now. So if you're not into spiders, time to zone out. Because especially for folks in Colorado, this is now spider season. All of my Black Widow calls were in October, November. And, you know, I got to say, I love it. It's a classic. It's a very fun time for me as a toxicologist. It's not so much a fun time for the patient. But we have 2 venomous spiders in the United States. We have the Latrodectus, which is our widow spiders, and then we have the recluse spiders, which are Lux oceles. We got 1 venomous caterpillar in the Southeast United States, that pus moth caterpillar. And then the brown recluse is not naturally found in Colorado. But thanks to globalization and trade movements and people traveling, we do occasionally see one come through. Our widow spiders are one of 3 different variations in the United States. There's the Latrodectus mactans, variolus, and hesperus. And there are many, many, many species of widow spider worldwide. They are really interesting because unlike the snakes, which demonstrate this ton of variability, like place to place with the venom, spider venom is very similar. It is almost identical worldwide. And you can use Australian widow spider antivenom on American spiders, and it works just the same. I wouldn't, because there's obviously a ton of like logistical implications and complications from doing that, and not to mention the fact that it wouldn't get there in time. But in theory, it does work. Only the ladies bite, which is where we get that term like Black Widow. And that venom is something called alpha latrotoxin. And it's really fascinating because these spiders have different venom constituents. They've got an alpha latrotoxin, they've got some other latrotoxin, but it is alpha latrotoxin is specific to human mammalian cells. And so while they have other latrotoxins that will harm insects, this is the only one that causes us any problems. And what it does is it causes uncontrolled release of acetylcholine and norepinephrine. And if you think back to like neurobiology, acetylcholine, we talked about it before with the organophosphates, it causes lots of like neuromuscular twitchiness. And then norepi is just like your Levothyr. It causes tachycardia and hypertension and a lot of those sorts of symptoms. So you tend to get sort of numbness and tingling and crampy, sort of like large muscle pain that tends to present as like belly pain, hip and back pain. You get some weird sweating patterns, especially like around the bite site itself because of that acetylcholine effect on the sweat glands themselves. So that direct effect causes you to sweat. So you get like localized sweating. You can get piloerections, so your hairs can stand on end, like only in that area of the bite site. And progressively over time, patients will get more and more generalized symptoms. It tends to progress over hours, and they're usually pretty uncomfortable. And the diagnosis is made basically by exclusion, and if they didn't see the spider, and then figuring it out later when you've done other interventions, because finding the spider is super helpful and it really narrows his diagnosis down. But after a bite, there isn't a ton to identify it. Like the wound doesn't look like anything. It like might be a reddish patch. You might have a little spot. And as a result, historically, there's been a ton of patients who have been spider bite patients who have gotten really complicated workups when it turns out to have just been the spider bite after all. Little kids in particular, especially if they're pre-verbal, can have wild symptoms. They can have really rigid bellies from all that acetylcholine affecting the abdominal wall. They can have priapism, so erections essentially, because of that norepinephrine effect and the parasympathetic nervous system causing that thing to happen. And if they can't tell you, like, I got bit by a spider, it can be challenging for folks to narrow it down to that differential. The treatment for these bites is going to be benzos and opioids. Yes, I said both together. I know we've all had it beaten to our heads that we don't mix them. But because of that effect, that you're getting all that acetylcholine stimulating all those muscle groups, getting lots and lots of muscular contraction pain, and the fact you got this norepinephrine effect, both together are helpful. And so this is one of those rare times where I'm going to recommend giving both. Yes, you can start with one and see how it works, and you can titrate to effect. But oftentimes, like if you've got somebody who is uncomfortable, the answer is give both. As long as you're able to monitor their airway and you're clinically like keeping a close eye on them, you can give both, and it can be helpful for them to get both. There is an antivenom, and it exists in this country. It can be harder to get, at least in the Denver metro area. I have never had an issue getting it. Colorado Springs, I haven't had an issue using it, but it's not always available readily. That being said, if you use it, it does work really, really well. However, widow's bite, these bites are not life-threatening. They're misery-inducing, but in the generally well person, you're only going to be uncomfortable and you won't die. It can last about a week if you don't do any sort of treatment for these bites, and so you can be uncomfortable for a while, but generally speaking, they are not fatal. Antivenom will reduce their misery very quickly. Like people are generally better in about an hour and a half after antivenom infusion. But it's expensive. It can be hard to get. So people don't want to necessarily pay for it or can get it. So you won't die if you don't. It's just, it can be nice if you've got it. And we can send patients home if they have been envenomated by these widow spiders. They can go home with benzos and opioids or just opioids alone. However, the individual physician wants to figure it out with that individual patient. As long as they're like feeling better, they go. There's two spiders. So recluse bites are generally not an emergency. We spend a lot of time panicking about brown recluses. They're not, in my opinion, worth panicking over. These lesions will evolve very slowly over days to a weekish. Very, very, very rarely it's associated with a hemolytic anemia, and that tends to be South American recluses and not North American recluses. But these spiders are generally really small. They're timid. They don't want to like mess with you. And so if someone feels they were bitten, it's probably not one of these guys because they're just like teeny tiny. Like that's the penny. That's the spider. Their bites are generally not painful. And so if they like say they felt it or, definitely got me like, their venom is a sphingomyelinase, so another like sub branch of that phospholipase family. So it causes really nasty, slow ulceration of the skin. And that's the problem with these bites is that like chronic sort of wound. As I said before, it evolves slowly. So if it's something that's like actively changing, it's probably not a recluse bite. If there's pus, it's probably not a recluse bite. If it's evolved over less than 3 days, it's probably not a recluse bite. If you've got multiple, it's not a recluse bite. There's a fun study, not a validated scoring, but if you Google it, not recluse, there's a paper from JAMA Dermatology discussing all of the signs and symptoms that make it probably not a recluse bite. And that's, as you can imagine, most wounds, not a recluse bite. Furthermore, people are really bad at identifying the spider. One of the fun trivia facts, if you look in the center of that screen there, recluses only have 6 eyes, not 8. So they have 3 pairs of 2 eyes each. And so if people think they have found a recluse, the answer is they probably didn't. There was a fun paper written by an entomologist in California about a decade ago now, where he had professionals, physicians, pre-hospital providers, veterinarians, and like other people send him, quote, brown recluses, and 0 out of 38 were actually a brown recluse spider. So, yeah. But wait, there's still more. Scorpions. So in the United States, scorpions are very rarely found outside of Arizona, Nevada, and Southern California. And we only have one medically significant scorpion in the United States, which is Centroides sculpturatus, the Arizona bark scorpion. This guy's technically a sting and not a bite, because that venom is located in that little bit up here in the tail, the telson. And it is an ion channel interactor, so it changes our sodium channel conductance, and it kind of acts like widow spiders do. They are generally not that harmful for adults. Kids tend to get much sicker from a scorpion sting than an adult does, basically just because it's more body size to dilute the venom itself. And so when we're using Anascorp, which is a anti-venom for scorpions, it's almost exclusively in kids in Las Vegas. It's all places I've ever used it. That similar to the Black Widow is that uncontrolled norepinephrine is what is the problem with scorpion stings that can lead to cardiac problems and cardiogenic shock, a la other catecholamine-based disorders. But it is pretty uncommon to get that. And then, yeah, they don't exist outside of Southwest. But they are UV reactive, which is actually how you can find scorpions. So because of bioflavonoids and beta-coumarins in their exoskeleton, they will all fluoresce. So is there anything else? But wait, there's more. So I was going to talk about all bitey things. So ticks. I wanted to include this because there is actually an interesting, like, super meta, like, crossover with ticks that we'll get to in the next slide. But there's actually something called tick paralysis, which is mediated predominantly by dermacenter ticks in the regions we're talking about here in the United States, and amblyomma ticks that they have a toxin in their salivary glands, and it could cause an ascending paralysis that looks an awful lot like Guillain-Barré syndrome. It is very, very, very rare. Like, there's about 50 cases of it in this country in the last 50 years. So it should not be the first item on your differential. But if someone has been out hunting and hiking, and now they've got this ascending paralysis that is starting with ataxia, and now they've got leg muscle weakness, and now they've got, inability to sit up, and they're having progressive symptoms, like, it is not a thing to think about. But again, very, very rare. But wait, there's even more. So, as you may have heard before, there's a syndrome out there called alpha-gal. And it's associated particularly with Ixodes ticks, so those hard-bodied ticks like that guy over there, Ixodes scapularis, in particularly the Appalachia region, Kentucky, Tennessee, kind of progressing into the Midwest. And the problem with this is that people who have been bitten by ticks and have a prolonged tick bite can develop a meat allergy to pork and beef in particular. And some people find that very distressing. Because what happens is essentially we develop an immune response to a sugar in their saliva that we as humans don't digest anymore. And it becomes very immunogenic to humans, but it is present in other animals, i.e. animal meat. And there was a study published, originally identified about 2017, and a study that came out this year that suggests that ANAVIP in particular might be more prone to allergic responses in people who have alpha-gal syndrome. Now, we're talking about like a 6% risk of reaction versus the under 2% for all comers. So it's not like a huge number. People aren't going to immediately like drop dead from it. But if you've got somebody from like Kentucky, Tennessee region who spends a ton of time outdoors and now has a snake bite, it might be a thing to consider in the future. We're not quite there yet to like totally change practice, but it is a fun thought and slightly terrifying and really cool from like a multi-biologies hybridizing sort of way. All right, we're almost done, I promise. I know I'm kind of over time, but we're going to play a quick game of venomous or not. So you don't have to shout it out or anything, but I just want to go through it because a lot of people panic about snakes and you don't need to. What's this guy? It's a hognose. They're little. They're cute. They'll play dead if you pick them up sometimes. You can tell because it's got that little flipped up nose there. They look kind of like rattlesnakes, but they're not. What about this guy?
They will also shake their tails.
Yeah. So yeah, there's another one in here though that does that too. So yeah, this guy. This is just a Great Plains rat snake. It's very cute. Cute little snake. Now, I didn't talk about coral snakes in this lecture because for the catchment area, from what I understand, no one is in the southeast. But this guy kind of looks like a coral snake. Is it a coral snake? No, it's a little milk snake. They've got those stripes. Only in the US can you apply red on black, you're okay, Jack. But I wouldn't, because coral snakes are notorious for having highly variable color patterns. And then you got guys like this guy who are totally harmless. And if people can't remember which way that rhyme goes, they'll harm a totally harmless snake. So, yeah, don't do it. What about this guy? This one is venomous. So this is that midget faded rattlesnake we talked about earlier. So Crotalus oreganus concolor, again, small, isolated towards the southwest of the state, not terribly aggressive, but venomous. And then what about this guy? Or this guy? Also standing up, looks kind of like a rattlesnake, kind of being mean, non-venomous. These are bull snakes. They can get quite big, and they can bite, but they're not venomous. A non-venomous snake bite should be managed like any other wound. They can, in theory, carry salmonella and other bacteria in their mouths, and so you should do wound care and tetanus. But generally speaking, from a venomous snake bite, the secondary risk of infection is quite low, less than 2%. The venomous, non-venomous snakes, it might be a little bit more because their teeth are different. But yeah. So this last piece of like fun trivia: what's the most deadly animal in Colorado?
The human.
Correct answer. Well, that animal was all about mosquitoes. 20 people died from West Nile virus in Colorado in 2024, and it is on the rise and spreading quickly. And so West Nile mosquitoes, which are Aedes, they are active both day and night, and about 1 in 150 people who get West Nile will develop encephalitis, and 1 in 10 of those people will die from it. So they mostly have non-specific fever, rash, joint pains, or stuff we think about with bad mosquito-borne illnesses. But yeah, when people get really worried about snakes, you shouldn't be worried about snakes. You should be worried about mosquitoes. So kind of as like a final thing, how do you tell if a snake's dangerous? If you leave it alone, it's probably not dangerous. I am, again, like very pro leaving snakes alone. That is just my personal thing. I don't like people killing snakes unnecessarily. And so this me. And that's my kitten there. He helped with the lecture, of course, yes, a couple days ago. If you need to get a hold of me, that is my email down there below, KarenMushlerDO@gmail.com. I am happy to chat at any time. And now I will close out of this so I can actually see if there's any questions here.